Maybe if it's possible to diminish just the light, to decrease the light, please. Okay, it's perfect. Madame, David Jones, dear friend, thank you very much for your invitation. We tried to make this presentation in English and maybe in two voices, okay? I start with the presentation of this conference, the new surgery, la nouvelle chirurgie, as the beginning of the aesthetic surgery. Along the first album of the review of the new surgery, directed and founded by Dr. Dartig, which exposes pictures, technique, and results, it could be read as a definition of aesthetic surgery. The aesthetic surgery is constituted of all surgeries with a plastic purpose to improve natural or acquired defects of the human morphology with a prejudicial impact on the individual or social value. Then, a series of pictures on comparative clinical cases for which the author wrote that those pictures disclose all deceptions. They are about retidectomy, nose surgery, breast surgeries, but also ptosis, basoexophthalmia, and orthognathic surgery, which could be considered today as paradox, because ptosis, exophthalmic, and dysgnasia have most of all functional consequences, except the fact that aesthetic and look could be assimilated. It could be strangely notice faces with mask or hidden by a voile with a certain part of transparency which shows a beautiful lady with pleasant forms, he wrote. There is a clear reference, moral caution, scientific caution, to two names of the reconstructive surgery world belonging to the Gueule Cassée, Dr. Maurestin and Dr. Sebilo. Amalgam of words, of course, but is the aesthetic surgery actually a new surgery? Is it a sort of an agreed dischrony, or at the opposite, is it coming from a break or a reaction? Referring to the reflection we had more than 10 years in an article of the Dictionary of the Medical Thought on the same subject, we will try here to answer to this question. The idea is to compare the procedure used during the World War I and the present procedure with a point-in cut and the slight modification of the meaning of the words as to ensure a better identity, and finally, wondering on possible tilting of a medical practice which historically strongly will determine it was a cosmetic surgery founded at the 19th century in the United States. By essence, there could be only compromise or arrangement between surgical procedure, which occurs a skin, or mucosal effraction through a skin approach with an unfading signature, and the willing to give to this body part the disappeared beauty. In contrario, as soon as the surgery is modifying the normal anatomy of the patient, in removing the tumor, in repairing the fracture, in restoring a lack of function by reconstruction of an acquired defect, or in modify the growth, the body could achieve unwillingly an aesthetic improvement. Is there an aesthetic surgery? Could be possible to give a precise definition of aesthetic surgery? Is it possible for the surgery to be only aesthetic? Referring to the factual story of the surgery from the beginning of the 20th century, there are many aspects, especially regarding the historic and intellectual context. There is no information regarding the relation between the different surgical teams between both sides of the Atlantic Ocean before the First World War, and less regarding the Asian world. There is, at this time, a sort of crystallization in one point in Europe with a meeting of numerous armies coming from the whole world with their own medical doctor and surgeons. As examples, Sir Harold Gillis, English surgeon, despite his strong personality, was dedicated to a Belgian ambulance in 1915 and then in the British General Hospital in Rome before coming back in England. The Great War allowed in a strange meeting the required conditions for a new type of surgery devoted to disgrace and look improvement. Despite some precisions regarding the vocabulary, should be pointed out to the word disgrace as dysrhythmy, abnormality acquired or not with only aesthetic consequence in comparison with the felt normality by one individual or the whole society at one time. The word dysmorphia should be opposed. Embryologic malformations, gross abnormality with an organic functional consequence added to the aesthetical aspect too. It is only the fact that this surgery never existed before. In 1907, in the United States, Miller had published a book entitled Cosmetic Surgery of the Face. It is also well known about the first surgery of Joseph in Berlin in the end of the 19th century and his handbook, Handbuch der Kosmetik, published in Leipzig in 1912. But during the war, because of the number of the seriousness of the disfigurement, the surgeon, even non-specialist, have had to face it always in the same time the rising of the techniques and the specialization of some of them. Two different truths should be mentioned. The fact that reconstructive surgery and aesthetic surgery are definitively undissociable because it is the same names of surgeons that will be later mentioned for the development of the cosmetic surgery. The second thing is the necessity of specificity of the face in both fields, certainly because the wounded faces, gueule cassée, survived after their wounds, but also because the mutilated, visible, exposed face remained in the collective consciousness a warm memory constantly reminded to our imagination. Could it be also possible to consider that it is a reaction of the patients and the surgeons to which led to the craze of the aesthetic surgery? Nothing is less true. In 1919, Raymond Passot reported in the Medical Journal, "The aesthetic surgery is now in the situation the reconstructive one was few years ago. Often at this time, the surgeon who promotes such a plastic procedure had usually problem to convince the other medical doctors. Many published cases of reconstructive surgery of the face during the First World War had changed the mind of those. And he said, my master Morestin liked to say, if he suffers from a face mutilation, he better prefer to use a prosthetic device than a surgical solution. Now, the reconstructive surgery is accepted and the aesthetic one is still in quarantine. At the same period, he reported a paper in France with Julien Bourguet. It was his first work on aesthetic surgery of the facial wrinkles, forgetting the reference to the British surgeons. Despite the substantiate the idea that the Great War was the only determining element of the specific surgery is rather poor. Not only because that the works have already been published, but because Passot and Bourguet have not been involved themselves in the battlefield. It is well known that Bourguet had visited Joseph in Berlin between 1914 and 1916, and that at the same period and in the same place began the psychoanalysis. It is more thanks to Adler than to Freud, who later was in conflict with the first on that subject, that the aesthetic surgery found its justification. The concept was that based on the theory of the organic inferiority of the psychological answer of the body fronts of the disease and its discrepancies. This theory was very well known in the United States. That way completely justified the feeling guilty to be an unnatural procedure. The surgery could be widely developed from this period and between the two wars. Coming back to the personality of Joseph, who since 1898 began to resect a nasal hump through the direct skin approach before to decide finally to proceed by a hidden approach thanks to this opened rhinoplasty 5 years later, is deliberately to deal with the problem of Judaicity. Joseph, a son of a rabbi, orthopedic surgeon, was working all his professional life to elaborate the technique of a rhinoplasty for which he was internationally recognized. This surgery, almost only dedicated to the precedent nose, had led just to use the word of carcinologic rhinoplasty. There was certainly at this historic period a real willing of the Jewish people to liberate themselves of this nasal curse. It is also the thesis of Marcel Marx in New Faces, New Future. He said, the surgeon tries to liberate the soul in modifying the appearance in the way that it could be matched with the normality. This concern to erase the primary mark of the race, and it is not so paradoxal that those papers was published in 1936, just after Joseph in the United States at this time of the highest period of the Hitlerian fascism. This concern were later authenticated through the painting of Andy Warhol in the same purpose that the Japanese ladies requested the slitting up of their eyes by surgical procedure. This constitutes the foundation of the aesthetic surgery and liberated it definitively from the yoke of the physiognomy or other disciple of Gall and Bertillon. The First World War had definitively confirmed the link between reconstructive surgery and aesthetic surgery through the surgeon. The word cosmetic was most of all used in the United States. Main importance is given to the plastic surgery word. Etymologically, the surgery of the shapes could be extended to all types of surgery. This adjective is used for visible shapes than superficial ones without any specification of the involved organ or tissue, bone or soft tissue, or of the purpose, reconstructive or aesthetic. This qualification is now completely dedicated to the surgical discipline with that name, the plastic surgery or the plastic surgeon. Those links became obvious through the meeting in Great Britain of the Big Four, Gillis from New Zealand, and McIndoe, Maulane, and Kilner, who gave to the plastic surgery its whole independency. In 1931, Maurice Kulst and ENT surgeons from the Sebilo School in France and Joseph Wone in Berlin had the idea to gamble all the published paper in his colleague in creating the first review of plastic surgery, International Review of Restorative, Plastic and Aesthetic Surgery, soon replaced in 1935 by the Review of the Reconstructive Surgery, with participation of numerous surgeons of America and Europe. This marvelous neologism, which summarizes itself the spirit of this specialty, will not survive after the Second World War and the publications ended in 1938. The official beginning as a scientific society of this specific surgery confirms once again the principle of no division between reconstructive and aesthetic surgery. If the subjects of the first papers are usually focused on facial surgery, as the paper of Kulst himself, a case of aesthetic surgery of the nose, intervention results which confirms the idea of this new aesthetic dimension which liberated the reconstructive surgery known from the old ages. It is now the time to ask ourselves, is there any philosophical heritage on which the aesthetic surgery is based? As the image of the artist's creation as the aesthetic surgery participating to the philosophical movement? Is the appropriation of the word aesthetic created by Baumgarten involving this particular surgery in a mission, specific ethics, which guided its history with an implicit consciousness? The answer is firstly clearly negative. Rising almost 2 centuries after the concept was formulated, it could not deal with the fight between ancient and modern. No question of the beauty. Its worries are elsewhere. The goal is certainly not to obtain the beautiful, but to erase the mark of ugly. It is only thanks to the evolution of the techniques, the opposition between the different teams, the fight between the followers and perhaps still today the inside break, which feels the surgeon himself sharp between the traditional medical ethic which he spontaneously subscribed through his educational input and in opposite the business of the beauty. The body became then a new religion, than ipso facto surgery became, because of the aesthetic question, an instrument of the philosophical reflection. It will be not true to consider that reflection is only an ethical or moral aspect as heritage or a phenomenological tradition, and that aesthetic surgery will be only the device of the liberation of the body, the reappropriation of the foreign feature characteristic of the flesh. To cancel the natural disgrace after the repairment of the different mutilation or correction of the malformation, that was the beginning of the aesthetic surgery, which was liberated from the constraint of the anesthesiology or asepsy, from the moral constraints of a century during which the positivism tried to erase, from the social constraints which a certain scientism coming from the 19th century, and finally it liberated itself from a type of psychic palsy thanks to the psychanalysis. To correct the disgrace of the aging shape was the second purpose of the aesthetic surgery. The story of the facial lifting is on that point of view eloquent of the evolution of the concepts through the evolution of the techniques. The surgery of the aging face, as it was described on the first papers, with some figures, drawings, and photographies, or often poor quality, is not based on the definition of the aging concept as a ptosis of the soft tissue with its corollary, the lifting of the tissue. It is a wrinkle which bars the forehead, the cheek, the neck, that the lifting should arise. It seems that, as reported by Miller in United States, Cole and Hollander, the aesthetic surgery purpose a skin excision on different levels to correct the wrinkles of the eyelids, cheek, and neck. Obviously, according the principle that the design of wrinkles of expressivity is in orthogonal position of the muscular tractus, there is excision allowed to stretch the skin in tension and also the subcutaneous tissue, but request a scar instead of the wrinkle. The principle of the excision strictly laterally positioned to hide the scar in the scalp border occurred later. Is it Bettman in 1920 who report the first picture? In 1928, Joseph improved it thanks to a retro-auricular positioning. Paradoxically, Passot and Bourget in France never referred to the American paper, and they practice with firstly segmental cutaneous incision, excision, than removal of the skin. This silence regarding the British works could match, as Vrebo's report, with a complete lack of scientific exchange. Just after the war, with this recognized catalytic part of the medical energy, and at the time that the surgeon will visit few years later to their American colleagues, this fact seems as a paradox. Finally, it is simply true that there was still no specific review and the broadcasting of the paper will be delayed. By the repositioning of the scar in the lateral part of the face, the surgeons realized in 1920 a double revolution. The symptomatic treatment of the aging, wrinkles arising, they realized an etiologic treatment against the ptosis from a simple excision and suture that transforms the surgical procedure to a larger reveal of the tissue of face and neck. It is Joseph Bourget who first reported the skin removal. He wrote, "Sometimes it is requested to remove the whole skin of the parotid area to displace it towards the air to decrease the nasolabial fold." Despite either the result of this large removal of the face, even with a strong fixation, were not stable, nor the approach allowed by the tip of removal showed to the surgeon that it was not only a problem of surface, but on skin, but also muscular attachment. Then the lifting became more complicated with more procedure on the deepest structures with removal of adipose tissue or fixation of some deep fascia. In 1925, the paper reported by Virenque about this subject is eloquent. Everything is here noticed. Even if the title of the paper remains ambiguous, the wrinkles disappear as an aging process. The skin is only the revealing of the ptosis of the sustained tissue of the face. The double originality of this extended removal of the skin and the deep fixation of the tissue was the basic process of the surgery of aging face during the 70s. In 1960, Aufricht improved the principle by realization of several pits which were long time used. Concerning the history of the head and neck lifting and the principle of aging faces, thanks to a urge step in time and also deeply in the tissue, it is necessary to follow Skoog in his depth dissection, allowing to reposition both depth and superficial layers. At the same period, Firmin meets Perronnet, Chitticini in France showed the continuity of the subcutaneous muscular and aponeurotic system described by few anatomists and used by Skoog. They name it as SMAS, superficial musculo-aponeurotic system, but in French language, système musculo-aponeurotic superficiel. Since that time, multiplying the different level of dissection, going alternatively from one to another, and sometimes added a more deep one, always preserving the facial nerve, the surgeons treat always, according to the request of his patient, his morphology, the thickness of the tissues, the skin elasticity, to lift and to fix the ptosis tissue by aging and under the weight, but always with the respect of the morphology. It could be also noticed that Tessier wrote about the face lifting. It is only a succession of compromise procedure, and he also said, whatever was the effect of rejuvenation, it is impossible to go 20 years back. The patient seemed younger or very younger, but he is always becoming other. That's all. That way, despite it will also be other, why not to accept it and will to be radically an other? With such a huge experience in surgery of craniofacial malformation, Tessier described the facial mask lift. That is to say, to harvest the whole soft tissue from the skeletal base by a double approach, coronal by scalp and intraoral to named the deep facial lift, with an highest suspension of the tissue and the temporal aponeurosis. The cultural evolution of this technique is not only linked to the deep dissection of the face, to the concept of a facial mask of the face, including the skin, the subcutaneous tissue, the muscle and glands, but also to the dissociation with the skeletal never modified. This revolution is not linked to the willing to not only rejuvenate, but also to realize a metamorphose of the face. Finally, it is linked to a more architectural conception either of the surgery and the expressivity of the face too. It is certainly more by culture than intuition that Paul Tessier jumped this step, adding to the mask lift some osteotomy of malar valgization, remodeling of the orbit, and canthal repositioning. By modifying the skeletal base of the face, it changed not only the relief, adding a third dimension to a surgery, which was at this time only realized by lifting, pulling the structure, but it modifies the physiognomy by changing the points of fixation of some muscles of the facial mimics. Beyond the presented results, sometimes marvelous, sometimes disturbing, this global approach of rejuvenation of the face prefigures the nowadays procedure. In a remarkable paper entitled Full Face Regeneration in 3 Dimensions, a facelifting for the 3rd millennium, Ramirez confirms the feeling of the surgeon that the aging was primarily through aseptosis of the tissue, the more visible effect, but always linked to a sort of atrophy of the tissue, fat and bones. The cure of the ptosis could be added by classical and well-known surgical procedure, even more complex. More difficult was to modify without risk the volume, even if the surgery of the skeletal architecture was known, particularly thanks to the mask lift, which deals with that dimension. It is the mobilization of the adipose tissue and the added procedure of fat grafting described by Coleman, which allowed to take in account this volume dimension according to well-defined criteria. Withdrawn into itself in a way creased, the plated face, the wrinkled face recover its youthfulness and freshness as soon as its tension and its volume are restored. The objective flashing of the light reflects itself on the signated surface of the cheekbones and cheeks. Surprised by the quality of the result shown on the picture in complete coherence with the pertinency of the argument, it seems obvious with Jacques Lévignac also to think that in terms of aesthetic surgery, the face is seen not in 3 dimensions, but in 5 dimensions, with the insertion of time and motion dealing with the ended goal of facial surgery named eurythmy. In the second part, after this historic aspect, we would ask ourselves with Mrs. Professor Sylvie Testelin if the facial transplantation we have had the chance to perform 10 years ago, almost 10 years ago, is aesthetic surgery or reconstructive surgery or so. And I give maybe the microphone. You have a microphone, okay. To Sylvie Testelin by record to the conference of Madame Cherichi about Alexis Carrel, because the father of the transplantation, it may be Alexis Carrel at the beginning of the 20th century, just before the First World War. Sylvie, please.
Thank you. Because certainly we passed from a reconstructive procedure to a replacement surgery. And that's exactly the border that we would like to point it out here, because of course we can deal with transplantation as organ, like we see here Joe Murray who done this first kidney transplant. But nevertheless, could it be possible to imagine that face transplant could be an organ transplantation? That not only a question of definition, but the function, like an organ, is certainly expressivity and motion. Of course, you can have the testimony of Mr. Murray, and Mr. de Vauchel received it in just a few months after he did it, but because it was so strange, so that the reception, and we can deal after that on mediatization, it was so strange that we could imagine to transplant a face for whom is not survival surgery. How can we imagine to live with the face of another? And that is always another sort of aesthetic dealing, of course. But with that strength by Mr. Murray, and referring to the difficulty of Mr. Barnott in 1967, we can have more persuasion for everybody, and with the improving of the techniques and the procedure, and we have our persuasion that reconstructive surgery is so difficult for the face that the nature could do it better than us. Just try it. And try it is also a very good present from the team of composite tissue transplant, because this story of face transplant is a double story. The story of reconstructive surgery, but we know it, and the transplant surgery of tissue. And they begin in France too in 1998 with one hand, and here is a result of 2 hands. It's not a cosmetic surgery, it's functional surgery, but also cosmetic surgery, because we usually have discussion with them, and they say, oh, it's sort of, for one of them, it's sort of the hand of pianist for a hard worker, so it could be strange also. And don't forget that the people see the hand, and you don't see your face. So it is another sort of a cosmetic or aspect surgery. And so parallelly to this transplant surgery of composite tissue, you have we have the experience of reconstructive surgery of the face. And we know by our results, for example, in 2003, we have a very long discussion with our colleague in Amiens about the solution given to this little boy after a dog bite without any lips, so no function. He cannot eat and speak normally, and what about his growth? And so at that time we imagined to do a conception of surgery with no added scar. That is to say, just bring it function to go to the adult age. And so we imagine with Mr. Langelet from Brussels this prefabricated flap, which is not technical, but just a little muscle with contraction from his limbs, and we put it after preparation as a lip just to have the contraction. With that result, of course, is not good, is not morphologically good, but it's functionally good because he can eat, speak, and go to school, etc. And on that point, we know that for our first patient, we can only do sort of ugly scar instead of lips. And that's the first point. And the second point was the possibility to reimplant faces. And here you have the old facial replant. So you can imagine this little girl with this scalp and face, and it was replanted, and it was reported in 1998 with this marvelous result at the adult age, of course, but our tissues is his tissue. There is no problem of compatibility of tolerance, of course, and it's a sort of surgeon dream to have the scalp, because you cannot find other scalp in your body. You can reconstruct lots of things. What about the other team? What about the world? The world have lots of research program in US, of course, in London. They ask about the ethical point about this face transplant, also in Paris, and everybody had people disfigured. Imagine that they could do something with transplant, but who will be the first? And the first, because of the tolerance, and because you need a donor. And for example, you have the rats of Mrs. Semyonov just before, and she made hundreds of rats, but never do it on face. And perhaps because we have a chance to be in France and we have the chance to face a patient. That is a key point. Face a patient. And after, we know that what we can do and what we would like to do. And you persuade people of ethical and every committees and so on with the picture, with this picture before. The problem is that they would like to have the picture after to say yes, but we have no. So we face them with the picture, say what we could do. And so it's a long trip, but now it's obviously easier. All over the world is easier. So short report, and a parallel report of the three of them who had been performed in Amiens in 2005, 2009, and 2012. Very different cases. Sorry for the shocking picture, but you should see the backstage to understand what's about cosmetic function and so on. So the backstage is traumatic for dog bite, fireworks burn, and after eye blood flow vascular malformation. That is to say benign tumor, vascular tumor, but eye blood flow. That is to say a sort of vascular bomb in your face. And you heard it, and every morning you say, perhaps it's my last morning, because if it's bleeding, you cannot stop. Just put your and pray. Okay? So for this lady, it was 22 years of bleeding and no idea about if it's his last day to live. So we make a modelization, preparation, dissection, reaching personal protocol, and so on, to have near the donor the possibility when it's a D-Day, that is to say somebody calls, there is a donor of all organ, and it could match regarding the skin, regarding the sex, regarding ABO, biologic, but the skin matching. And so at that time, you will receive a picture, and we say, why not? Can you ask, secondarily, to the family, if you can add a part of the face, the part we need, because we make a sur-mesure surgery. We don't take the whole face, and we can discuss about that, why we choose that for us. So the facial transplant for the three of them, first soft tissue, because we need only soft tissue, is a dog bite only in the nose and the lips. Second, with the mandible, because the fireworks take out the mandible. And third, we remove the tumor 4 months before, 28th of February, because it was bleeding and we'd never know if it could be succeeded in removal. And we know that there is a risk of death during the surgery. And we need to be all the team in the first race to have more chance to begin for the second race. The patient knows that, disfigurated during, nobody knows how long time after, to wait for the facial transplant, and it was just in June. So she waited from February until June, completely no face. So, and the little things is really innovative because we need sentinel flap, that is to say skin, taking from the donor, putting on the body somewhere to make the biopsies, to avoid the scar on the facial transplant. Organization, we can deal about during hours, but organization, team, everybody is volunteer, and prepare. We share the team in 2 parts, one near the donor and one near the recipient. And the first step on the donor was to take a print, to have the mask, exact mask of the donor, to be able, and we try also, work a lot with the prosthesis and all anatomoplastalgists and so on, to be able to reconstruct the face as much as possible identically with the picture before, because the family should not have any mark at our passage. So there is no mark. So the color, the shape, and we have time because we are the first who operated on the donor, and after everybody to take the heart, lungs, and vessel, and so on and so on. So we have time. We take time, but we need artists to do that, of course. So our part of that. The opposite is near our patient. That is to say, dissected face, find the vessels, the nerves, the bone, everything to plug the transplant. We need to plug it. And so it's a huge work, exactly the same time. So the team is divided in 2 parts with resident intern, nurse, prosthesis, etc. And we go each part. We never know where. It could be in Amiens, it could be in Lille, it could be in Marseille, and everybody is okay, prepare, check, manage to make the retro planning at the time I have the phone call. So here's the search, just to imagine, under the eye until the larynx, there is nothing. Okay, so it's a very waiting transplant. And you can imagine after when we see the function of that. So the most important time and the pleasant time for the patient, for the surgeon, yes, is the revascularization. That is to say, now the transplant is a part of the body of your patient. And here, of course, scientifically it's very important to shorten the most possible the ischemic time for the muscle, for the quality of the muscle, certainly, but we don't know. We try to make research on that. And the beautiful things when the lip came pink and stayed pink for life. Backstage is nerve, vessels, bone, shape, projection, etc. With the weight of the piece, it's very difficult because usually we have large open and we do it that way, from this until superficial. That way we have back. We make artery, vein, we put back and we make that way. And it's so difficult to do that. Only few people in the room. It's terrible because there is so many people around the neck, and another for the sentinel flap. So 2 teams, 2 microscopes, and I don't know, 50 people in the room. First picture, first result. So it's we discovered that this picture is very, very important, and Mrs. Kramades could testify of that, because the patient needs to make the job, to understand how she was and how she came. And so we need a sort of a passage. And so we use that picture because it's so strange for some pictures after, just to finish. this little report, but because that is just morphologic. What about the function? During that time, there is a lot of, because we have now 10 years, so it was 31, certainly more, because officially 31, because there is lots of strange also cases. And with etiology, more traumatic cases, no other vascular malformation, Recklinghausen, always benign tumor, of course, perhaps one day, but for the moment we should be very careful because of the side effect, and the side effects are tolerance, and the tolerance give lots of risk of disease, and you put your patient in risky time for his life, so you should never forget it. Some morphologic result, and so you can compare before after, but is she now as she was without this face transplant, with this normal face? That is what about identity? What is it could be or not, but you can face with your face your identity card or driver's license, and you can see that is also you, but not really you, but how many times, and it's so not so difficult. For the other, some are very not competitive, but rather satisfying, and it was a very good indication. But for this patient, it was a beer hunter, and he lived 3 days from travel from the hospital. So one day in China, one day he changed his medicine, we think, for Chinese medicine. But so rejection time, and he died. Recklinghausen disease, a very good solution, but always with a case of tolerance, and we don't know about the evolution of the disease itself, because it's not only the face, of course. Recklinghausen is congenital malformation. Some of question about this face in two parts. The first, because the first is, firstly, is the result of previous surgery. So it's just a question of difficulty, mistakes, I don't know. We don't know, but we have to put in question what we are able to do as surgeon. And the result, because certainly of the fragility sometimes of the team, because now we know the backstage, are not precisely exactly the piece the lady needs to have a normal face. And after there is lots of lifting, removal of the parotid, and so on. And she's almost blind because we meet her in US. Some others, just for you to have in question, for what, for which part, how could we imagine to do both hand and face? Both hand and face is a huge weight, 10 kilos of tissue, and so 10 kilos of toxin and risk of infection. So he died just in intensive care. We don't know why exactly, and so for the result of the function. For the other, it's always a question of discussion about the school of reconstructive or not. But never forget that if you can do reconstructive in a good way, it always escapes the tolerance. So you have to put that in question. Boston team, we like to work with them because we discuss a lot with them. They make dissection in Brussels with us. For these cases, it was burn cases, and the patient is okay, and they have a very strong team behind them, and everything is clearly defined and thought. After, there is a sort of guilty of US regarding their soldier from the war, and here we make this picture with how he was before. So it's always difficult because he can live like that, but it's not his face, and he would like to replace. But after is another man, another person, but it's also aesthetic. I don't know. Here, the patient, the problem is that no eye, no nose. So I cannot be on your place of psychologic, etc., but no face. And so now, of course, he's still blind and so on, but he had a face. He can face the social life and have a a blog, and he had a real life, and is a wedding, etc. So what is face transplant regarding identity, regarding tolerance, regarding reconstruction? What is the balance and the risk you take with your patient? Because it's his decision and your decision to go with him for this adventure. No, it's just a conclusion, my dear.
It's a conclusion.
Yes, and you write the conclusion in between.
Between aesthetic
So
and
yeah.
continues.
Good.
Continues.
So just a few words, I forget, about the function. Of course, we have the text, excuse me. 4 days after, you should go for the physiotherapy. And you have, of course, lots of improving results, and it's very fascinating but time after time, it's like end. It takes 2 years, 5 years, and still today. She met the kinesiotherapy every 3 or 4 months during when she came. Lot of research field, and we discover so many researchers and interest, and it's also a role in our opening mind, of course, because not only neuroscientists, but also dermatologists and everybody look to find what could be rejection, chronic rejection, because we don't know about that. And so in another part is a plasticity of the cortex, because the green part is just before surgery, you see, and here on the motor place, there is just 2 months after surgery, after the transplantation, a new corticalization, I should say, of the transplant. This part recognize the face as is, like the hand, because the first reverse experience was with the hand, for example, of course. What about the psychological stakes? The grafted people reaction. Of course, you cannot imagine what could be to be disfigured, because you are not. But for this lady, it was a 5/5 cases of Boston. It was a chimpanzee woman. You can have sort of, I think, hours of videos in the internet in every language, and because she would like to be reconstructed. And so she was in Cleveland, and she was referred in Boston. And in Boston, she make a complete face transplant with this normal integration of the new integration to social life. It's so important for her, but after some problem. And little coming back with Isabelle about what she feels, how she feels. And a new.
Ils m'ont redonné une identité. Parce que quand on n'a pas de visage, on n'est rien.
So nothing to say, when you have no face, you are nothing. So what is identity? So we deal with 3 types of identity, of course, and you can also make a complete congress just on that. Recognize yourself psychologically, of course. Recognize a belonging to society. Give a face to have on your card. And also to be recognized as individual people. What defines the face? And just a picture of the patient, so Isabelle, 4 years before the transplantation. So it could be her without any transplant. It's just a question of expression and motion and daily life and how she's integrated in her life. We don't change the patient. She had exactly the life she had been before, except she had a new family in Amiens. Family depends on the day, of course. That's your turn.
Yes, so thanks a lot, Sylvie. No, just in conclusion. So I would like just to come back about the etymology of the word aesthetic. In the definition given by Baumgarten, the word aesthetic comes within all the senses. The beauty declines itself according to the different sensorialities. Okay. Regarding the word cosmetic, it shares with the word cosmic the same etymology. In those conditions, we could attest that the aesthetic surgery comes under the cosmogonic dimension of the individual, strange sliding of the semantics of the words, which at the time go by takes them away from their profundity. Thank you very much.